Welcome, everyone. It's a great pleasure to be here and invited to this great program. And I'm really excited about this. And so in these days, we wear devices on our body, as well as there are devices in our environment, and they have sensors which have the capability of monitoring our behavior. And this is well known. The ability of using the output of the sensors efficiently and effectively for behavior and health monitoring and diagnostics is the holy grail of the mobile health discipline these days. And this is becoming very much important in the context of this pandemic. I was talking to collaborators who are working on Alzheimer development and of techniques to monitor Alzheimer and monitor the early signs. And they were saying they are unable to meet the people in person because of the patients in person because of the problems with the pandemics. And this is on the screen is the clinical guidance of management of remote consultations and remote working for clinicians. So everyone is starting to learn how to test patients remotely, how to ask the right questions, and how to provide care not physically. I will explain a little bit more later, but now we also have this context of COVID testing. At least these are two of the headlines in the US and in the UK, where there are reports that people find it difficult to find a place to get tested. We're running out of testing. So there is an increased opportunity for digital technology to help to remotely give indications of disease and indication of possible progression and even just of diagnostics. So I will first describe our general aim for automated diagnostics based on sound signals and its motivation. This is the general agenda that I have for a large project running for the next 5 years. And then I will describe our work, which is specific to this pandemic. So why would we want to do automated sound-based diagnostics? Well, the microphone is a sensor, as I call it, that is embedded in many platforms we already have and live with us. And they're quite cheap to be embedded even in new devices. And even on the headphones I'm wearing right now to talk to you, there are microphones that can capture sounds from inside and outside of my environment. In addition to that, sound is able, so devices are sticking with us all day, either because they are in our environment or they are in our body. And therefore, the continuous sensing and the continuous input of that signal is easy to be achieved. So in this project that I have for the next 5 years, which is funded by the European Research Council, we aim to collect large in the wild data set that are related to diseases, including cardiovascular, respiratory, and digestive. And because most of the diagnostics would have to happen in the wild, the models we build for the automatic diagnostic based on sound need to be resilient to noise and heterogeneity that is in the environments we collect the data from. In addition to that, we need to be able to make this model in various steps. So you would have the ability to screen for a class of diseases, maybe to classify a specific disease in, let's say, a specific cardiovascular disease. The holy grail of understanding the progression of a specific disease in a specific person is also something that this technology can help develop. And obviously, the ability to react quickly to indicate an emergency once certain kind of conditions are met is also very important, but needs levels of accuracy that are perhaps different from the screening level, where you can afford more false positives than we can in an emergency. As a systems researcher, I'm interested in integrating all this technology on device, which would mean that the the logic to understand and to diagnose sits very close to the user itself, to the patient, and their data, their sound data, which is quite sensitive, would then not go out of this device. The integration with other sensors is important, and of course, as I've explained before, the continuous monitoring, so the ability to continuously assess dynamically is important. Also, because we live in a world where I don't think we would have machine learning substitute clinicians. The interpretability of the prediction is important, and the fact that clinicians should be kept in the loop in the cases where the machine learning to me is there to aid the clinician more than substituting. And I will explain perhaps a little bit of that perhaps at the end. So the ability to diagnose and detect symptoms or indications of behavior through sound has been going on for a while, and I have a few examples. This is an example of our work by using voice to capture emotions through the microphone of a mobile phone on device. So this is a study from 2010. It was published in UbiComp, where we show that by using Gaussian mixture models or machine learning that was trained on actors' voices, we could match users' voice emotion as expressed in their daily life through the microphone of and recorded through the microphone on their phone. This was done all on device on a Symbian Nokia phone, which was a phone that had a very good battery at the time. If you remember, this wasn't even a smartphone. The screenshots you see there were our translation of it into an Android phone many years later. And voice diagnostics have been used for other diseases through the years. This is a MIT Technology Review report that shows that voice analysis could be used to diagnose diseases such as post-traumatic stress disorder or even heart diseases, as the heart diseases are impacting voice in the sense that voice could be different. For example, hoarseness in the voice could be generated by some diseases, and some stiffening of the respiratory apparatus. Obviously, other researchers are looking into this. This is a recent paper from colleagues in University of Washington, where they used 911 calls, so emergency calls, to show that they could match from the voice some signals of that could indicate cardiac arrest detection. They also then added noise to the data they had to show that it would even be possible to translate this onto our devices, smart devices such as Amazon and Google devices that sit in our house. But so the signal of the voice is not the only signal that could indicate disease. As it concerns the heart, we are very familiar with using ECG, electronic cardiograms, to understand the electrical signal of the heart. And electrocardiograms can be quite cheap and embedded in devices. For example, the Apple Watch already has an ECG feature that allows you to do a one-lead ECG on your wrist. But there are diseases related to the heart that are not detectable through electrocardiograms. On the right here, you see a picture of valve-related diseases, which could be detected from sounds rather than electrical signal. The listening to the heart through auscultation is something that doctors have done for many, many years, in fact, centuries. However, this technique requires a skill that many doctors need to train for a long time to achieve, and therefore it's something that is going almost discontinued, because this is substituted by echocardiograms, which are a bit larger machines, and they require a bit of expensive equipment, but less skilled, because the interpretation can be done more easily on the image. And in fact, when we tried to get data to look if we could do cardiac analysis of sounds automatically, we found it hard to find simulators like this one called Harvey in the UK. The newest hospital in Cambridge does not have a Harvey. We had to go, this one is the one living in Birmingham, because doctors are not trained anymore in the art of listening to the sounds that much. It's considered difficult, it's considered obsolete in a way as far as a cardiac is concerned, very much. However, data could help us developing techniques that instruct machine learning to understand the signal of our heart as well as respiratory signals. However, as I said, because this is not something that is happening much, there is virtually no data about it. And it's very difficult, both for respiratory and cardiac, to have data sets on which we can work and try to see if machine learning can do something automatic about that cheaply. There are some attempts in recent years. We have seen a few. This is a paper that was considering small data sets of cardiac sounds, and they try to detect heart murmur automatically through signal processing techniques and machine learning. But one of the questions that the general concept of understanding if we can diagnose something is something I've discussed very much with clinicians. And sometimes I would highlight that there are problems, there are questions still in understanding what can be detected, because the ear of a doctor is not the same as the ear of a clinician. Perhaps a machine can hear more things continuously as well, and therefore what we can diagnose might go beyond what a clinician could diagnose in general. And so this is an interesting area that we hope to explore. And this again is the idea that continuous sensing perhaps is something, while your doctor can't stay with your ear attached to your body to understand what what you have, a machine can, a small device could give that signal, and therefore can open the door to new diagnostics that we haven't considered before for different pathologies we haven't considered before. So we have started building devices. This is a simple device that one of our master students produced. It has a microphone. It tries to run things on device, and we're trying to explore what we can do in an environment when the user is moving and where we have limited battery and limited processing capabilities, and actually limited and cheap sensors, in fact. So while we were doing all this, COVID happened. Now, COVID is, as let's say, characteristics of a respiratory disease. It exhibits some characteristics which are related to our respiratory apparatus. And we know by literature that actually it is possible, though, as I said before, there are no many data sets around this. It is possible to automatically try to detect different diseases, asthma, chronic obstructive pulmonary disease, and pneumonia. I have one that have been considered for automatic analysis. So, we brought all this together, and with two colleagues of mine, one in biological physics, the other one is an expert of infectious lung diseases. We have started a large data collection. So at covid-19-sounds.org, we have launched apps in Android and Apple, and I can have a completely different talk about the difficulties of getting the app approved at the time of a pandemic where COVID was exploited by all sorts of apps to collect or invite people to give data. So getting them approved by the Google Play and App Store was really hard to convince them that we're not just collecting data for the sake of it. And so I will now explain first what the app does and what data we are collecting and why, and then I will explain the initial analysis that we have conducted. These are 3 screenshots of our iOS app. As you can see, we are collecting sounds. In the first screenshot, we are collecting breathing sounds. So we ask the user to breathe deeply 5 times, then we collect 3 coughs, and then we ask them to read the sentence on the screen 3 times. So here we're collecting breathing, coughing, and voice. In addition to this, we're also collecting their indication of the symptoms that they feel, the medical history that they have, as well as if they tested positive for COVID in the last 14 days before, if the test was negative, if they never tested. So this is kind of information we crowdsource from the user. And here are the numbers. So this is even now it's kind of an old picture. The numbers are growing by the day still. And on the top right, you see the growth. We did a couple of media campaigns, and so the numbers went up. One thing I should highlight is that because, especially in that period, April, May, people weren't being tested much for COVID, we still have a relatively low number of positively tested. This number has gone up now, we're around 300, but it's still comparatively lower than with respect to the total number of users we have. On the bottom, you see the participant age and countries distribution. The line PNTS, prefer not to say, indicates that some users prefer not to give us their age. And you can see the country that has the biggest entry is none, which is the users didn't give us their location, so we allow them for that. Our biggest user base is in Greece at the moment. I think it's because the media campaign there through some of my collaborators went really well. And the second is obviously, as we would expect, in the UK. This is a graph that indicates the medical history of our users. And as you can see, this is a subset of the data, by the way. And I should highlight that we're still analyzing this data. We just collected it in the last 4 months, so it's a bit hard. But this is an indication that of the medical history, which is reassures us, because the diseases you see there are chronic common diseases. So high blood pressure is the most common. The most common couple is asthma and high blood pressure. You can see the same graphs for symptoms of non-COVID tested and COVID positive, which, so these 2 groups are groups of users that have said that they've never been tested for COVID on the left, and the ones that have said they've tested for COVID. There are, in this particular graph, I highlight that there are a much smaller proportion, but I should highlight immediately that one of the symptoms that come up in the first, let's say, I think there's 10, is smell and taste loss, while that symptom does not come up in the non-COVID tested. So we know that perhaps, although this data is crowdsourced, there is some truth in the data that we have. In fact, the common couple of symptoms is tightness in the chest and smell and taste loss. This is a paper that at the time we started looking for analysis was already out on arXiv, and we thought was interesting. It's a small study that shows that they collected some data, and they showed that the cough samples seem to be distinguishable automatically from samples from other diseases, people with other diseases. We also looked for this article. There's an article from Rita Singh in CMU, interviewed in Forbes, that essentially, so the spectrograms you see in the picture are spectrograms from our data. So these are coughs, and you can see the light bits are essentially the 3 coughs that we asked the users to do. On the right, you have healthy coughs, and on the left, you have coughs that assumedly are COVID coughs. One thing that Rita Singh says in that article is that while in a healthy cough, you have vocal folds movement at the end, so the blue circles on the top right, and in wet coughs, you have a high energy spread that could be seen in the distribution of the spectrogram, the green. In the COVID coughs, there are some low frequency oscillations that could be specific to COVID. And so, this is just to indicate that there are various groups in the world that are trying to see what features could be looked automatically for in the data, and then employ machine learning to do so. And so what we've done was that we worked on this, and I'm going to describe what we found with our very, very preliminary analysis. This is a paper that appeared in KDD 2020, is in public access on arXiv. So this is the system we have. We only use for this particular paper only coughs and breathing. We exploit traditional audio features, and we combine them with features extracted with a model that is pre-trained on other data, so on YouTube audio. And the model spits out, so we input our data into this model, and it spits out features that we then use in combination with the audio features of machine learning. And then we do the traditional split in our data in 80/20. We use a smaller data set, of course, than the one we collected, because we only pre-process some. And I'll show you now with which task we have looked for. So as I said, we only use cough and breathing for the moment. We haven't used the voice yet. And these are the three tasks on the table on the first three rows are the three tasks we consider. So can we detect a COVID positive, declared COVID positive, and a non-COVID person? Can we detect a COVID positive that also indicated a cough from one that also indicated a cough but said it was negative? And can we also distinguish asthma? One problem we had was that the COVID negatives, we didn't know if they had COVID or not, because people weren't being tested. So in order to help that, we considered that at the beginning of April, there were countries where COVID was not prevalent. And one of these countries, for example, was Greece. And so we use countries like that to as our control group, as our group of non-COVID users. So I really trusted that. The features that we use, as I said, are traditional machine learning audio features, as well as the features outputted by this VGGH model. So the typical features are from the raw signal, the onsets of the cough. This is 3 coughs up there. And then we trim the signal, and you see in the orange, that's a trim signal with the 3 coughs. And we use different features such as period and duration for typical indications. We also use frame level features that are on 100 milliseconds of the signal, and they are the typical frequency features that you would use in this case. And the paper has more details on this. I don't want to go into the details. MFCCs are the usual features that are also used, and we use the derivative and the second derivative of that too. Experimentally, we run 10 runs, 20 train and test for 5 cross-validation and the usual precision and recalls measures. And these are the results. As you can see, the tasks on the first column and the modality that perform best. So for testing COVID tested and non-COVID tested, we use both modalities, and that's the best modality. While for the other two, it looks like there was a marginal improvement of one or the other. In the fourth column, you see the feature type, and that means that we were using just the normal audio features, just the VGGH feature, or both. And both, which is number 3, was the one that was performing best in all cases. Now, one thing I should say here is, okay, the numbers look particularly good, but the recall, which is the most important thing, so the ability to really find all the people with COVID is the lowest measure here in most of the cases. And so we want to look more into it. Also, the ability to distinguish from other coughs and have more data around it is something that we're still working on, and we hope to solve very soon. One thing I should highlight is that we have additional data that we haven't analyzed yet, but is very precious, because when the user finishes the questionnaire, it would be indicated to him that a notification will be sent to complete the questionnaire again. And every 2 days, we ask the users to complete the questionnaire. On the left here is the distribution of our users. How many entries, how many times have they completed the questionnaire? Now, we have anonymous data, so I don't know who these users are. We don't collect email, we don't collect anything. So I would like to publicly thank the first couple of users that have given us more than 100 entries. And this will be very precious data for us. So continuous information can indicate how a user progresses into getting COVID, how his sounds change while he's getting COVID, or even how their sounds change while they're getting out of COVID. So we need more data of this kind, and it's really, really precious. And we hope to do more analysis on this. Now, as I said, where do we stand with all this? Well, given the current situation with the track and trace and the fact that it's hard for people to get tested, we believe that digital technology that even has a certain kind of imprecision could be put as a pre-screening technique for this in the near future. And therefore, we hope to help developing these and help the system, essentially, because at the moment, it's really difficult. And with this, I would like to finish my talk. I should say, please contribute the data at the URL that is above. I would like to say that if you go on the URL, we have a way to share the data. The data is sensitive. We cannot just put it on the website. We have we are pre-processing. So at the moment, we're sharing a subset of the data as described there. And we are doing it through institutional agreements for academic research purposes. So you can ask us to have the data with an agreement. These are my collaborators. So that's actually the people that have done most of the work while I kind of overseen all of this. And so I would like to really thank them.